Today we are going to talk about how we will approach the patient of UTI. So let's start with the assessment of the patient of UTI. Number one, we will take the history of the patient. In infants and pre-verbal children often present with the non-specific symptoms such as they will complain of fever, they have a complaint of vomiting, poor feeding, lethargy and irritability. So we have to rule out all these symptoms in the history. In older children and in the adults, we have to rule out the different symptoms, such as we will ask about the dysuria, means pain during the urination. We have to ask about the urinary frequency. Either they have too much urine, they have to go to bathroom for too much urination, or we will ask about the lower abdominal pain and about the loin pain. So these are the symptoms in the older children and the adults, and we have to rule out. They will tell us about these symptoms. And the third point in the history, we have to ask about the previous episode of UTI. We have to ask about all the symptoms, either fever, urinary frequency, lower abdominal pain, or the loin pain. We have to rule out the previous episode of UTI so that we can know either it is a new generating UTI or it is a recurrent UTI. So the next step is the determination of severity of UTI. We can assess the severity of UTI by identifying either it is upper UTI or it is a lower UTI. Basically, the clinically distinction between the upper and the lower UTI can be difficult, especially in the younger children. But in the upper UTI, it is called cystitis. Upper UTI is called cystitis, and the clinical features of cystitis include dysuria, means pain during the urination, urinary frequency, urinary urgency, and the lower abdominal discomfort. These are the symptoms and signs of upper UTI. In case of lower UTI, this is called pyelonephritis. In this, there is a systemic features are present such as fever, malaise, vomiting, and the loin tenderness. So the next step is the management. And when the patient comes to you in the hospital and you are suspecting a UTI, then what we have to do in the management? So in the management, the first step is the investigation. In case of children, if you are suspecting a UTI, you should collect a urine sample, and then you have to perform dipstick or the microscopic screening. These are the initial tests, and these can guide you about the initial management. But after 24 hours, you will repeat the urine culture to confirm or adjust the management as appropriate. The most important point to remember in collecting the urine samples that you should collect the urine samples prior to starting antibiotics. Unless the child is seriously unwell or requires immediate therapy, otherwise you have to collect the urine sample before starting the IV antibiotics. So, how to collect the urine? What are the precautions and what are the methods of the collection of urine? First of all, there is sterilization. Before collecting the urine, you have to clean the perineal or the genital area with the saline soaked gauze for about 10 seconds before collecting the urine, so that no organisms from the perineal or the genital area can enter into the sample and it will false the result. So there are different methods of the urine collection. The preferred method is called midstream urine sample collection. But in case of infants or the small children, midstream urine sample collection is not easy. So we have to collect the urine through clean catch. In this, appropriate pre-continent children who cannot void on request but are not seriously unwell. You will take the urine sample by clean catch. But the gold standard method in collecting the urine sample is always suprapubic aspirate, because in suprapubic aspiration of urine we collect the sample with minimal of contamination, and the contamination rate of in suprapubic cystostomy or suprapubic aspiration of urine sample is only 1%. And the last method of collecting the urine is catheter, Foley's catheter. If the patient is unable to void or there is a very little urine remaining in the bladder, we can catheterize the patient and we can collect the urine sample from urinary bag. So now we have collected the urine sample, we have the urine sample, and now we have to perform the different tests on the urine sample. The first step to perform on the urine sample is urine dipstick test. Urine dipstick test, what is urine dipstick? It is very useful screening test to guide the initial management of the patient. If there is presence of leukocytes and nitrites, these are strongly suggestive of UTI on the dipstick test. But dipstick test is very less reliable in neonates and the young infants, because in neonates and the young infants there are large false negative results are present. Next step we have to perform on the urine sample is urine microscopy and culture. Laboratory microscopy can augment the dipstick result to guide the initial management. If there is a presence of bacteria and leukocytes on microscopy, these are the strongly suggestive of UTI. But if there is a presence of epithelial cells, this suggests the skin contamination and the poorly collected sample. Remember, if there is on urine microscopy of urine sample, there is epithelial cells. This will suggest the sample is poorly collected and there is a skin contamination. So in this case, consider recollection. A positive culture with sufficient growth and pyuria. This suggests the UTI. Growth of a single organism from any collection method suggests the infection. Other investigations we have to perform is to check the renal function and consider the renal ultrasound if the child is seriously unwell or it is not responding to the appropriate therapy after 48 hours. This is a very key point. Always remember it. If the patient is not responding, initial therapy after 48 hours, consider the renal function test and the renal ultrasound. So we have talked about if the patient is not responding to the appropriate therapy after 48 hours, then in this case we have to check the renal function test and we have to perform the renal ultrasound. And you have to consider the blood culture and the lumbar puncture for the unwell infants less than 4 weeks old. Or if the sepsis or the meningitis is suspected at any young age, you have to perform the blood culture and the lumbar puncture. So, after confirming the UTI from various laboratory investigations and the urine samples, we have to go for the treatment of the patient. There are two types of treatment, oral antibiotics and IV treatments. The treatment should be started with the oral antibiotics. Any child who is seriously unwell and the most infants under the 3 months should be admitted for initial IV antibiotics. In case of cystitis, there is 3 to 7 day course for the children, and in case of pyelonephritis, there is a course of 7 to 8 days in the children. And this should be IV antibiotics in the most infants who are seriously unwell and who are under the 3 months of age. Oral treatment, we have to give the cephalexin antibiotics. The dose of cephalexin is 33 mg per kg oral, 12 orally. For pyelonephritis, the dose of cephalexin is 45 mg per kg oral, 8 orally. In case of IV treatments, we have to recommend the empiric IV antibiotics, and this includes gentamicin plus benzyl penicillin. If we have to continue the gentamicin after the 48 hours, then we have to check the gentamicin level and renal function before the third dose. But if the patient is stabilized, then we have to switch to the oral antibiotics when clinically improved, as soon as tolerating the oral antibiotic. So now we have to do the follow-up of the patient. If the child is seriously unwell, or the child with a renal impairment, and the boys who are less than 3 months of age, these patients should have a renal ultrasound prior to discharge. And the next step, if the child is not seriously unwell, or the child has a first episode of UTI, consider an ultrasound but on the non-urgent basis. But routine antibiotic prophylaxis should be continued in the patients of UTI. Specialist follow-up should be arranged for children with recurrent UTI or non-renal anomalies. Consider the consultation with the pediatric team if the patient has one of the following conditions. Number 1, if the child under the 6 months of age. Number 2, if the child has known renal tract anomalies or not responding to the initial therapy. And number 3, treating any child who is seriously unwell, kindly always consider consultation with the pediatric team. And when to transfer the patient, any child who is requiring the care beyond the level of comfort of the treating hospital. If the child of UTI require the comfort level of care beyond the treating capability of hospital, always refer the patient. And consider the discharge of the patient when the patient is tolerating oral fluids and the oral antibiotics, then we can discharge the patient. So, for the next beneficial medical related video and stuff, don't forget to like and share the video and subscribe to my channel. Thank you very much.